Okay, so lung cancer, again, everything that's in yellow, I have deemed as being important for the class. And anything that's in this color, blue or green, whatever that is to you, to me it's green. But that one's like more extra information that's not really as important. Heparin drip and ABGs, maybe like yeah, maybe like a question or so on at least knowing how to interpret it for sure. Interventions for the ABGs, not as much. It's more, I think it was more about just being able to read it. And then the heparin question, practice your math problems for that, I believe. Um, but it won't be anything too crazy. And then again, when it comes to like the heparin drip questions, if you were to have to do like a whole workup on it, you get the paper that tells you like how to use the numbers because you don't memorize those numbers. It's all dependent on the conditions, dependent on the policy and whatnot. So it's just about knowing how to manipulate the numbers, and you're not really memorizing much for the heparin drip. Okay. So now, here, kind of what I have written is again the general information. A lot of people come in late due to, or a lot of people don't come in due to, it has a lot of really vague signs. And a lot of the people with lung cancer are already smokers, and people that some of these already kind of come with being a smoker. Then we can talk about that in a little bit, but it's usually the late symptoms that come in, like coughing up blood and all that stuff. So a lot of these people are treated a little bit on the later side. There are two types, at least the two types that we really focus on here is non-small cell and small cell lung cancer. What do you guys know about this one? Like just kind of like the broad idea, like which one's worse, which one's less bad, which one's easier to treat. So yeah, non-small cell. This one is yeah. So non-small cell. This one grows and spreads slower. Yeah, small cell is worse. So this one is going to be more fast growing. It's going to spread faster and it's more aggressive. So a way to remember it is small cell is small chance of living. Maybe not necessarily like literally, but that's like a decent way to remember it. Maybe yeah. As far as surgery and treatment, yes. So for this one, you can have radiation and surgery for treatment usually, because it's usually um, it can be caught because it grows and spreads a little slower. It can be caught earlier than the small cell one, which is usually caught a little bit later. So yeah, exactly. Yep. And I'll add that chemo. That's the kind of like the usual cancer stuff. The main thing here is just kind of the difference between the two. But again, nothing else is really required in terms of like knowing the difference between the two. Some of the general causes here I've listed smoking, which of course we know, secondhand smoking, anything that has like carcinogen, of course, that you're breathing in. Asbestos can cause mesothelioma, but you don't really have to really know too much about it. Honestly, don't hard memorize any of these stuff. Realistically, it's usually pretty self-explanatory. We already kind of think of smoking with lung cancer to begin with. And then the prevention is pretty basic stuff, reducing smoking. Those people that are at risk, maybe if there's like a family history or they are a longtime smoker, then they get screening done. Um, and then PPE is referring to like people that work with carcinogens or asbestos. They work in the mines.
No, they work in homes. My dad has to wear N95
Oh,
because
yeah.
the asbestos and whatnot, the walls,
Yeah.
ceiling, the popcorn ceiling.
Okay. So can you guys list some of the vague signs that kind of comes with lung cancer? So these are things where if you get a select all that apply, these are the things you'd be clicking for things to expect. So yes, coughing, insurance. Oh, endurance, endurance, like low endurance, or what do you like fatigue, shortness of breath. Yeah, shortness of breath. We'll kind of put wheezing into it, kind of coughing, shortness of breath, wheezing. They're very vague, right? And people that are smokers already kind of expect that. And we'll put fatigue over it. Yeah, you have less endurance and fatigue. It kind of goes again. These are all very vague symptoms. If you're a smoker, having occasional coughing and wheezing is like, oh, just because you're a smoker, so it gets brushed off. Um, Fatigue gets brushed off a lot because like, oh, you just didn't sleep enough, or oh, you have this physical labor job, so of course you're tired and blah blah blah. So it gets brushed over a little bit more. What about some of the late signs? We talked about a few of them already. Yeah, coughing up blood is definitely gonna be a late sign. Um, Coughing up blood, and that's called hemoptysis. In case they bring out the dictionary. Mention purulent sputum. Yep. Yeah, kind of weasels. Anything else that might come with lungs that are a little bit weakened up, they're not working as well. Anything else you guys can think of when it comes to all this stuff? Or even if it's general, late signs or general, we'll just fill it in as it goes. Yeah, wheezing. That one's kind of like an early thing, kind of just happens. Of course, it's gonna get even worse as it goes on. So, yeah, we'll include that there. Pain, yeah, chest pain. Chest pain, weight loss is like a general thing that happens with cancer. If you guys recall, a lot of cancers will try to create their own blood supply, so they take nutrition away from you, and that's where that weight loss and anorexia, as in like lack of appetite, come in. Chest pain, and that chest pain can occur as you're like breathing chest pain. These people kind of going with purulent sputum. What do you usually also associate with purulent sputum? What kind of condition and stuff? What's causing purulent sputum? People are higher risk for this happening in their lungs. Infection, yeah. So like pneumonia, like recurrent consistent pneumonia is one, and then that kind of goes with kind of pleural effusion, so having fluid build up in the pleural space, um, making it hard for them to breathe, making it they might need like a thoracentesis and whatnot to get rid of some of that stuff. Bronchitis. I'm sure that kind of probably kind of goes on with it. So like infection and inflammation. So kind of go with the chest pain. I would include, yeah, probably like just in general respiratory infection. I'll kind of just go all together like that. But a lot of stuff that kind of makes sense, right? You have coughing, shortness of breath, wheezing. We already associate a lot of this with respiratory problems. Pneumonia, I think coughing up blood. I think it's pretty easy to associate with cancer. A lot of cancer gets detected. Yeah, Breaking Bad, coughing up blood. And then the only one and then chest pain also makes sense if you have cancer. You can imagine that probably hurts to breathe. And then the only one that maybe less like obvious to us would maybe like the pneumonia, just having more infections there, more risk of infections. Everything else, though, I think is pretty like self-explanatory in terms of like cancer and like lung issues. And I'll add in like labored breathing here as well. So moving on from there, they did talk about how the different sites of the cancer can impact the person in different ways. So what do you guys remember about these three locations for the cancer? And you don't have to go in order, just like specify which one you're referring to, and we'll talk about it after. So upper lung, bronchi, peripheral. And then I have a picture after to kind of visualize exactly what he's actually like referring to.
True. Like actually.
Hmm.
Wow. Woo!
Yeah, so that would be upper lung. So this one will have severe radiating shoulder pain, and you can have the drooping eyes as well. This is due to pressure on nerves. Okay. What about bronchi or in peripheral? One of these especially requires you to be extra vigilant on the person because of ABCs.
Oh, no, I don't.
Airway obstruction risk, yes. So this person has risk of dyspnea and airway obstruction. What is a potential thing you'll hear with airway obstruction? Like, what kind of sound might you hear? Wheezing and stridor, yeah. And we recall, I know I worked with a lot of you guys in the skills lab, like actually doing like the lung sounds on that one mannequin, and we went over stridor. I think this was during 220 because we went over stridor, we went over, yeah, I think we had a scenario about shock. We just talked about shock. We talked about lung sound stridor. So that's like a big one. Stridor, that's a sign that the upper airway is clogged up and they are not being able to breathe in. Wheezing is a sign of airway, yeah, like airway closing down, restricting airway. Um, but stridor is like imminent, like they're hardcore struggling to breathe. And then remember for testing, when it comes to like wheezing or like people having like outward wheezing or having these stridor sounds, sometimes they'll see questions where they worded something like and then it suddenly goes away. Is that a good thing? Is that a bad thing? Like what does it mean when they're having all these sounds while breathing and then it just goes away potentially? Is that something you ignore or what do you think could be the cause? Yeah, it's bad because it means like that they're just actually fully, there's nothing going through anymore. So when someone is, potentially choking, and they're able to kind of still make some noise and kind of gag a little bit, it's less of an issue compared to like when they're literally unable to make any sound because that's how you know they're completely obstructed. So like my psych professor actually had like a joke where it's like the new nurses they hear someone wheezing and they go rush out to help. The experienced nurse ignores them because as long as they're making sound, it means they're good. And I thought that was funny. But um, and what about peripheral? Yeah, usually asymptomatic. And then we'll look at a picture so you guys can kind of picture it a little bit better. So right here. So this is going to be this is the Pancoast tumor. This is the upper lung tumor. So upper lung in this case is actually on the outside, with hence why it's interfering with the nerves. And you don't have to know the name of the tumor, but here's just kind of like the picture. So when it's saying upper lung, it's not referring to the inside of the lung, as opposed to the bronchi and the peripheral, which is actually referring to inside the lung, um, like so. So This right here, the tumor on the upper lung right here, it can interfere with some of the nerves and blood vessels, and that's why you have that shoulder pain. Anytime you hear like radiation, it's usually like a nerve pain or some sort of impact on like certain blood vessels and stuff. So your MIs can radiate to your back and to whatnot. And then you have like people with like diabetes that can have like neuropathy and they have like shooting pain. Um, so a lot of the radiation kind of comes from that. And then right here you can see the peripheral right here and the central slash bronchi because it's literally on like the bronchi. And these are the ones that can cause more obstruction, which makes sense because you can see like air is going to go down through here. If this is obstructing here, it's not even going to make it to the alveoli, which are on this side right here, for it to transport O2, exchange O2 with the blood. Here, obviously, it's still going to obstruct, but you have so many alveoli that it doesn't cause an immediate like issue as opposed to here where it can obstruct. Does that make sense? The seeing the picture make things make a little bit more sense. All right. Any questions so far? No, we're all good. I have listed here the staging. But again, I have it listed as this blue-green color because it's not important. You don't have to memorize this, but it's here for your own reference if you want it, but you don't have to know this. But here it can kind of show you how, um, kind of like you see that difference between the non-small cell and the small cell, how the non-small cell is slow growing, so you actually have a easier time staging them, I guess, and then the small cell is a lot faster, so it's basically like zero, like 50 to 100. You don't have like specific, more like detailed staging. It's just like 50 to 100 or 25 to 100. So let's move on from that because again, it's not really important. Here you have the different diagnostics that can be done for this. Between your chest X-ray, CT, and MRI, which one's more effective? And which one's more effective between the two, or can catch more?
CT
Yeah,
or
CT.
MRI,
Yeah, CT and MRI. These can detect
everything.
the tumors anywhere. Well, the chest X-ray is not going to really catch as much because it has to be, yeah, anything smaller than one exactly. Yeah, exactly. And that yeah, that kind of makes it harder. So uh, so that's why that's kind of the difference. So show tumors maybe um less than 1 centimeter. So that's why the CAT scan and the MRI are better. What about the PET scan? What's that for? So the PET scan is basically they give you radioactive contrast and then they do a full body, like a full scan. Yeah, it's to show metastasis. So the idea would be that if someone has metastasis, they get that radioactive contrast and they light up like a Christmas tree if they have metastasis. So show meds by following the that's the did I spell that right? I believe so because they want to see it kind of spread, like how is it spread? Is it because sometimes you have like metastasis to the brain, to the liver, to the bones. Why is this spelled wrong? It's just because there's no typo C. Okay. And as always, so here the bronchoscopy or the thoracoscopy, they can go in for visualization, but they can also get lung samples. And as we recall, biopsies is going to be like the most specific thing you can use to get an idea of the staging and whatnot. So a combination of your biopsy, your CT, and your PET scan kind of gives you that full picture. Like we mentioned, these people can have the prevalent sputum, so doing a sputum culture can be good because they might also be having like pneumonia at the same time. The bone scans there to kind of, I guess, like another way to see like metastasis to the bones. And ABGs to see if there's any imbalance in acid base, which can happen if your lungs aren't going too good, kind of like the same way how like COPD people are probably going to be have some respiratory acidosis because their lungs don't inflate all the way and all that stuff. Same idea. And we talked about thoracentesis can be done to get a sample as well for the pleural effusion and also to get rid of some of that fluid there. For the bronchoscopy, I have written down some of the pre-op on the post-op in case you guys could ask some of that stuff. It's pretty basic though, like pretty standard pre-op and post-op. MPO, informed consent. They'll get sedated in some way. Post-op is just make sure they can gag after. They have the gag reflex back, and then you monitor their vital signs until it's stable, and then they're good. So. And then here I do have some of the cancer complications. We talked about a few of these already when we talked about cancer in one of the other weeks. I think maybe it was for liver cancer or something. But these ones are the ones that are, I think, a little bit more likely to happen with these specific types of cancers. Superior vena cava syndrome. You have tumors pushing on the superior vena cava. Um, and this can lead to the backing of the blood due to swelling. And the main thing you really have to know is just like swelling in this uh upper area, so around the eyes, face, neck, and chest. So if you have swelling in that area, what might that lead to? Yeah, airway obstruction. Yeah, that's kind of one of the main things. So it kind of makes sense. You can kind of be like, you can kind of just simplify it to lung cancer. I'm worried about airway and breathing, so that makes sense. And some potential signs and symptoms that we already talked about when it comes to like airway obstruction, alter level of consciousness because they're not getting enough O2, dyspnea, wheezing, stridor. So a lot of stuff we already talked about. Maybe some headache and dizziness, lightheadedness. Um, Something that I know we talked about back all the way back in 220 when you guys had oncology is that there are they call it paraneoplastic. So these are some of the cancers produce their own hormones, and the lung cancers are particularly more likely to cause some of these, especially, well, these are probably like the main ones that they're more likely to cause. So having a general idea of it is good. This is probably like one of the most common ones that can happen is SIADH. So we'll kind of talk about all these things here. Um, I'm sure he went over it, but just kind of having a general idea. And this will pair up as well. These will pair up as well with your, I think week 6 or 7 when you guys have to do some of these conditions in more in depth. But for now, I don't know if you recognize this one right here, ACTH. So that can be one of the things that happens gynecomastia with this. So ACTH stands for adrenal, like the adrenocorticotropic hormone. So basically your yeah, it can cause Cushing's syndrome, Cushing's disease, probably Cushing's disease, Cushing's syndrome. Essentially this is going to be an influx of steroids in your body, and that can lead to something called Cushing's syndrome, Cushing's disease, that we'll go over in more detail later. The main thing you need to know probably is just like it can cause like the moon phase, so like swelling of kind of you'll have like swelling and increased weight in your like core, and then you'll have like skinnier arms and legs. You'll have things like Giselle mentioned gynecomastia, which is kind of like basically man boobs, like but it's like man boobs with like actual like breast tissue if you're a man. Um, Things like change in mood, change in your some of your electrolytes, change in your blood pressure, and we'll go into more detail then, but that's just something that can come up. I don't think that one's as important to know as maybe this one right here. So when you have increased ADH, you have something called SIADH, which is syndrome of inappropriate, yeah, antidiuretic hormone. So with that, just kind of, if you guys remember, this is all the way back in 212 when we went over ADH, and some of that other stuff, antidiuretic hormone. So if you have a lot of antidiuretic hormone, what do you think is happening to your fluids in your body? Yes, exactly. So your ADH exists there so you don't pee yourself to death by just kind of flowing all your water out of your body as you're drinking it. But
I
when you have too much, what was that? Oh, someone's talking. Um, yeah, so when you have too much of that, then you're storing all of your fluid, like your fluids are just staying in your body. An easy way to remember it is SI for soaked inside, because your body's full of fluid, so you have fluid retention. And this fluid retention, like you guys said, is going to lead to a decreased urine output, and it's going to lead to dilutional hyponatremia. So when somebody has a low concentration of salt in their body, sodium in their body, what are some things that could happen to to that person, if you guys recall?
Can you repeat it again?
Oh yeah. So when sodium levels are low, what is something that can happen to the person? So kind of remembering hyponatremia. Sure, muscle twitching, seizures, yes. So a lot of neuro-like symptoms. Confusion, yes. So like you can have altered level of consciousness. Yeah, like muscle cramping and twitching, weakness, more like cramping, twitching. Seizures when it's super low, so usually like under 125, a higher risk of seizures occurring. So those are the things you want to watch out for. So I would say this is something that's important to know because it ends up happening a bit more often with the people with lung cancer, because the lung cancer produces a lot of ADH. Your lung cancers will also produce a lot of parathyroid hormone, which in turn leads to increase of calcium in blood, which then leads to, well, hypercalcemia. And hypercalcemia, kind of like we talked about last time, I like to associate that with just like arrhythmias, maybe some muscle twitching and stuff as well, but arrhythmias is probably like your major thing that can happen here. And then the other very important one is your ectopic insulin. Ectopic meaning it originated, like it's making its own insulin, which is going to lead to it's going to lead to hypoglycemia because you're making more insulin than you're supposed to be making. So I would say these are like the major possible complications. So airway obstruction going back up to superior vena cava syndrome already kind of makes sense with this condition. It's lung cancer. The ones that are a little bit less intuitive are some of the symptoms caused by influx of hormones. But the main ones to really kind of worry about are probably these main three. You'll know more about Cushing's later, but these are probably like the main three that we can kind of decipher and treat. So if someone's hypoglycemic, they can get um, some sugar, some D50, orange juice, whatever. If they're hypercalcemic, then we know that they're at risk of arrhythmias and they should be like on an EKG, like a telebox, and assessed for kind of abnormalities in the rhythm. If somebody is having fluid retentions, we want to think about the hyponatremia and things like that. So these are the main ones that that you have enough knowledge to kind of respond to at the moment. And then with Cushing's, there's a lot of information on Cushing's, and they don't really emphasize it until later, so don't worry about it as much because there's a lot of different things that go on with this. Okay, any questions so far? Okay. So we're gonna move on to the management. So
Yeah,
our goal here is to
Olivia,
cure
let's
and
wait till we're
survival,
done with Chucky, okay?
enhancing the quality of life naturally. That's the idea. You have your different surgeries, and you have the radiation chemo, which we kind of already expect. I think we'll go into more detail about the different surgeries here. For now, we just know that there's pneumonectomy and lobectomy, and we'll talk about the differences in a little bit later. Here I just have a very quick review of chemo and radiation. Chemotherapy is systemic, meaning it's going to affect the whole body, hence why it's usually used for your higher stages, or even if it's just like there to it's gonna be a little bit more. It's gonna do a lot more. It's gonna do a bit more. The radiation's more localized to a specific area. So I'll just put some of the signs and symptoms that are important to kind of know with this. So your pancytopenia is going to be one of your biggest ones. So remembering that these people can have fatigue and all that stuff that comes with anemia. They're high risk of infection, which got to think about how they're already at higher risk of like pneumonia and stuff, and then how this can affect that. Thrombocytopenia, higher risk of bleeding. The chemotherapy can also lead to loss of hair, which is like very well known. Nausea, vomiting, also pretty well known with like chemo, and then potentially having mucositis, which is like sores in the mouth. So you'll have some cancer patients they get like special like mouthwash to help with that because they can impair their ability to eat and want to drink water because like it hurts to do so. And then radiation is localized. It can be there to kind of work together with the surgery. So maybe shrink down as much as we can of the tumor, and then so we can kind of excise it. I do have some signs and symptoms, but I don't think it was as particularly emphasized. But so um, because this is all happening like in that chest area, you can have inflammation of your esophagus, which can make it more difficult to swallow food. And again, with lung cancer, you're already kind of thinking of airway obstruction. So if you have esophagus that's really inflamed, it might push on your trachea and make it harder to breathe. But this person also should, at risk of aspiration, should be on a softer food diet. And then some general stuff to kind of go over. The radiation. Try to avoid the sun, soft, loose closing, just some general Kaplan-like questions that you might get on it. And we talked about tumor lysis actually last week, I think. So tumor lysis syndrome, this is when your treatment is actually getting rid of the tumors too fast. So you end up bursting the cells. And remember, we have potassium that's in the cells, so releasing a lot of potassium all at once. You can also get high amounts of uric acid. So your main treatment, kind of similar to rhabdo, is to flush it out. Flush it out with fluids, let your kidneys handle it a bit. And there's also allopurinol for the uric acid. And because we went over this last week, I'm not particularly like, asking you guys to like restate it again. So this was meant to be like a quick review. But now, some of the stuff that you guys can contribute to is like, what's the difference between a lobectomy and a pneumonectomy? Partial versus whole lung, yeah. So a lobectomy is you're getting rid of a little single lobe or a chunk. Pneumonectomy is the whole lung. And you do have two lungs, so that this means like one half of like one side. Some of your pre-op, again, a lot of the typical pre-op you've come to expect. Conformed consent, MPO, post-op, remember that they just had an incision, so you gotta think about like bleeding infection, all that stuff. Your use of your incentive spirometer, turn cough, deep breathing, managing their pain, and they could be on like chest tubes. So some of the post-op stuff. So this is again stuff for you guys to help me fill in here. So what are some things you guys kind of remember about kind of like the post-op afterwards? How do you want to position them on the bed? And what are some assessments you might want to do? Good lung down. Yeah, that's going to be one of your main things to recall. So if you get a question asking about what position after they get like a right pneumonectomy, then you know they need to be on the good side down. So that's important to know. Early ambulation kind of just goes with all of your all of post-op because you want to prevent DVT. So a lot of information you guys already know now. What about assessment of their oxygenation? How would you go ahead and kind of do that? Or what do you expect to do? What do you expect to assess? yeah, lung sounds. And it's pretty self-explanatory. What other two things make sense that deal with lung and oxygenation? Yeah, respiration rates, SaTo2. And it goes without saying, but we'll say it anyway. Difference between a lobectomy and um, a pneumonectomy in terms of lung sounds. What do you guys expect to hear? Mm-hmm. Yeah. If the lung is missing on that side, you're not going to hear anything. And then a lobectomy, what do we expect from that one? Yeah, diminished. Diminished. There we go. Pretty much that. So we have all that, and then maybe some other things that are good. We already talked about. We already talked about IS and turn cough deep breathe. How would you like the head of the bed to be? So we're gonna have them good lung down, but then also head of the bed, but someone with lung issues. Yeah, like semi-Fowler, so like 30 to 45 degrees. Nobody actually measures the degrees. You just kind of feel it out, but you guys get the idea. You want the head of the bed up, and they might need O2 supplementation, which I know is pretty self-explanatory there. Um, Pain management. So if the patient's saying that, basically, if the patient is saying that they don't want to do their IS or they don't want to make themselves cough because it hurts, that's where the pain management comes in. We can give them pain management so that they're able to do it because they're gonna need to do it. So that's a way for us to help them be able to do so because we want them to do it. So that's how that kind of goes down. Your incision care, again, you'll assess that for bleeding and for infection and whatnot. Um, and then in terms of like a chest tube, if they have a lobectomy, then they'll have a chest tube probably. And if they got a pneumonectomy, there's nothing really to kind of drain for in terms of like that's impeding the lung because there's no lung on that side. So the chest tube mostly just for the lobectomy. And yeah, and we'll go over chest tube later on the next outline. And then there's the infection stuff. So here I'm going to just copy paste um your ventilator acquired pneumonia bundle, and I would memorize this or know it very nicely for I would say for this class and then also for the next class. This will come up again and they will ask specific stuff about it. So I would know that. Okay. Any questions on lung cancer? Okay. Seems like we're good here. The sedation vacation, yes. So the idea is that these people are mechanically ventilated and usually they're going to be sedated. The idea is it's not really a fun time having a tube down your throat that's breathing for you. It will probably freak you out and that can impede with the kind of the treatment. But the idea is that you don't want them to be sedated all the time because that also means that they're not able to put their own effort towards breathing, and the goal of someone on a ventilator is to get off the ventilator eventually. So to do that, we will kind of measure their progress, adjust the settings on the ventilator, and eventually try to wean them off, lower the settings, and eventually kind of do like a trial to see if they can handle not being on a ventilator. Because that's always the goal. But the idea of sedation vacation is you're not sedated for a little bit of time so that you can um, do your best to try to breathe on your own or try to breathe kind of put your own effort towards kind of improving and making progress. Right? Laryngeal cancer, this is your neck cancer, basically. These are people that might have to use like a voice box and stuff like that. The risk factors are going to be some of the stuff that you would expect, like smoking. You can get it from overuse of voice, meaning strain your voice so much you're causing damage to that area, and similar to like esophageal strictures. So people that like purge a lot can damage their esophagus, and the more you damage, the more your body's trying to heal it, and the more it tries to heal, the more it can make mistakes, and that's when cancer can occur. So consistent damage to a place can lead to potential cancer, higher risk of cancer. And then alcohol, honestly, I'm not really sure why this one. Maybe it just kind of causes some irritation that eventually kind of leads to the same idea. And then warning signs. What are some warning signs you guys can think of?
You.
Let's see what you guys put. Sore throat, coughing blood, persistent cough. Yeah, these are all good. Yeah. Yeah, dentures not fitting is a funny one. I'm like, yeah, I guess I get that one, but it's like, oh, it's weird. There's kind of what I have. So non-healing ulcers, neck lumps, hoarseness of the throat, some of the patches on the tongue, sore throat, throat pain, difficulty swallowing, that makes sense. Maybe some shortness of breath because again, your throat um is right next to your trachea. Your trachea is like that area is like your esophagus and your trachea. And that area can lead to obstruction if it's inflamed and has a mass on it. So all of these little things here. Again, don't hard memorize anything here, but just like if you see it on a select all that applies, you know to click it. That kind of idea. That's as far as you need to really memorize anything for these things. Just as long as you see it and it makes sense that that's an answer, you're good. Don't bother trying to hard memorize and active recall it. There's no point. So here are some of the diagnostics. So kind of follows the same idea. Chest X-ray can detect masses, but the CT and MRI is more accurate. At the end of the day, your scopy that leads to a biopsy is your gold standard. You have a PET scan for metastasis and a bone scan. Again, that can be done just to see metastasis to bones again. So a lot of the same things that kind of go with the lung cancer. As expected, your goal is to remove and preserve. You do have two main issues. I have them as blank. So what do you guys think are probably some of the main issues that you can expect with cancer in this area? And I did talk about it, but let's kind of see what you guys kind of prioritize as the main issues. So cancer of the neck area. What are some things that were like especially like, oh, that can be bad. Aspiration's definitely going to be one. And you'll see that word come up a lot in some of the complications and management as well. And then kind of going with aspiration and going with neck cancer, you can expect the other one um, to be what? I mean, it's kind of obvious, so I don't even know why I'm trying to get it out. But yeah, airway breathing, airway respiratory. Pretty self-explanatory there. Um, so with this one, I'm also again going to include just a list. We already talked about radiation. We had our little review on it again. So I'm not going to go into too much detail on that because we already went over it. But some of the same idea still kind of applies. Because you're putting radiation on the neck, you want to assess the airway. That's going to be one of your biggest things. So again, as always, airway for everything here. This is one that's kind of random, I guess. Not really random, but like you don't really think about it as much because you have some of your salivary glands are going to be in that area. You can cause damage to them. So they can have a lot of dry mouth. So with these people having like a water bottle, maybe some gum or some hard candies to help them with like the dry mouth can be good. So it's just something to keep in mind. Just like, this person has dry mouth, give them a little water bottle so that they're just trying to keep their mouth from feeling like it's super dry. We already talked about hoarseness, which can get worse from the radiation, ironically enough. And same with the difficulty swallowing, inflammation of the esophagus. So a lot of the similar stuff that we kind of already saw with the other one still applies. So you're able to cluster them together. We talked about how chemotherapy can be, especially if there's metastasis, because it's systemic, all body wide. Your surgery. So with this one, um, you have the pre-op care. As always, airway with this one's going to be priority. If they're going to be on any tubes, uh, they should probably know how to suction themselves. At the end of the day, um, they will have a temporary leg trach at some point, or they could have a permanent stoma, which I think have a picture, maybe. Oh, I don't have a picture. Do I have a picture? I'll find a picture. So you can kind of get a look at that. But we do have two different types of laryngectomies. And the reason I don't have these as fill in the blanks much is just because I feel like it wasn't as big of a priority as lung and pleural space stuff. So that's kind of why it's just kind of like a let's just talk about it kind of thing. So kind of a similar idea. You have a total and a partial. So when you have a total, that means your whole voice box is removed. This person will no longer have a normal voice. They will have one of those um, like artificial voice devices that will of course make their voice sound weird, kind of robotic, and that's like a big thing that can impact like their self-image and stuff like that. One of the key things about this, though, is that there is no risk of aspiration because the way this has then been made, and I think the picture is where this kind of comes in, and I will look for the picture actually. Is that normally you have your trachea and your esophagus, they're right next to each other, and you have your epiglottis, which separates whenever you're trying to swallow, it covers the trachea. That way you don't swallow stuff into your airway. With this one, they take the trachea that is partway through they take that trachea and then have its exit point be like at your neck, so you have like a neck hole. And because of that, there's no longer any risk of swallowing down your airway because your airway no longer kind of has that point where it meets with the esophagus. And I'll get a picture of it. Let's see what we got. There we go. That's a good one. So that's going to be a key thing is that total laryngectomy, there's no risk of aspiration. So let's take a look at this. They separated this airway. This right here that you can see my mouse that says air would normally be attached like somewhere like right up here. And there would be this little point with the epiglottis where if probably like in this area where you can have food go down your airway. But because of the way it's detached and placed, that's no longer possible. It's no longer possible for food to make its way here because it's completely detached from this area. And so the stoma meaning opening, is now in your neck area. And that's kind of like what that's going to be. It's basically like a trach. Difference being that I guess the people with the trach don't necessarily have their trachea separated and their epiglottis removed and their trachea fully separated from their esophagus. They just have like a hole in their trachea. These people have it fully separated, and then that's just like their new airway entirely. So they entirely breathe through their neck. Their nose no longer, I guess, helps them, I think. It doesn't really do much for them anymore. It's through their neck. Yeah, so they can't use their nose or mouth to breathe anymore because it's no longer there. While someone with a trach can still breathe through their nose because they haven't gotten this part separated. Does that make sense? Yeah. So that's kind of where that no risk of aspiration comes in. And then there's a partial laryngectomy, which has risk of aspiration because they will still have their trachea attached at this point here. Kind of like I mentioned, these people will be on a trach and likely just like I think a lot of time it can be like a temporary trachea, but same idea kind of holds. They would have a hole here, but this part would still be attached, so they still have the ability to breathe with their nose and their mouth, um, and therefore they can still aspirate as opposed to the total laryngectomy.
Do you know person? Um,
Yeah.
oh, I have liquids in there. I smell like this.
Kind of like what we were called with the trick CPE. Well, I guess it wasn't trick CPE, but some of you did trach. Some of you guys did trach for your CPE. If your trach comes out, you have the obturator and you can attempt to reinsert it. And then that's kind of why I mentioned like having one that's same size and one that's a smaller size in case the inflammation gets to a point where the original size doesn't fit anymore. Because the obturator is there to smooth out the trachea so that when it's going in, it doesn't scratch the inside of the airway. And of course, we know sterile gloves when suctioning. But that's pretty much that. And these people can have normal speech. There's not too much crazy about the laryngeal cancer in terms of like being tested on. Here's some like extra stuff that I don't recall being heavily focused on. Um, your partial can have like a reconstruction of the neck area after surgery. And for the most part, when your main focus is going to be airway and perfusion. So perfusion to that neck flap. So kind of like I think it's almost like a skin graft, essentially. So you will report to the MD. When do you think you would report to the MD after having a neck tissue flap placed on you? I'll take a picture for that. Yeah, no perfusion to the area. So from that we can tell like it's cold, it's maybe a little blue. It's not really um kind of working out at that point. Exactly. Well, you wouldn't really have because you can't do a cap refill on. Well, I guess you kind of. Well, maybe can't really do it on the neck, really. But it's just like it'd be more like swelling and lack of like color and temperature abnormal. I would say just like yeah, like color and temper abnormal. So like you'll feel cold, maybe um kind of bluish and stuff. Also, kind of like with any like invasive thing, infection and stuff is always going to be a big thing for you to look at. Um, for some of the home care, again, none of this stuff should be hard memorized for this stuff. It's not as uh, big of a deal. It's just kind of like make sure you look at these and are able to recognize it if you see it. So the idea is having a shield for when you shower because you have a hole in your neck. So if you get water down there, you're getting water down there. Or a stoma guard. It's pretty much the same thing. No swimming because if you're going underwater, you're getting a ton of water in your stoma. It's not good. Skin barrier creams, similar idea to like when you have like your trach collar, you want to cause irritation to the skin. Similar to the trach, humidification of the air. So as people might be like on O2, helps to thin mucus secretion. Same idea with your trach. You have like a humidifier. Having a medical bracelet so people there's no bracelet so that people know that they're a neck breather just in case like in case of an emergency they don't notice the neck hole for some reason they should know that I guess they might think it's a trach instead of a stoma, but the idea is like if you're doing CPR and you're giving breaths, it's not really going to help if you do it down the mouth because it's not going to connect to the trachea. So if there are a full neck breather, you have to do the CPR breaths through the neck hole, which is very interesting. And then here's just some like standard like nutritional stuff. Because there's going to be swelling, they're probably going to be MPO for quite a bit. And if you guys recall from TPN, you want to always try enteral feeding first before you do TPN for kind of like you if you don't use it, you lose it, risk of infection. And then stuff that we talked about, aspiration risk, swallow eval. Here's some again extra stuff. This is pretty extra. You don't really have to know too much about any of this stuff here. Just know that like these people can have like they might burp their words. For like partial, they can help burp their words and stuff. They get speech therapy, but it's nothing for you to really know. It's just there if you want to know for some reason. If you have extra time on your hands, which I know you don't, so that's why I made it green blue. That's pretty much it for this part of it. Any questions so far? I believe the next part is a lot shorter. Questions, concerns? So, this is fine. And then we'll move on to the next part if nobody has questions. Not, like at most, I would think maybe like one question. But like I mentioned, it's just more about recognizing than hard memorizing. So, don't try to active recall any of that stuff. Just be like, if I see it, it makes sense. So, like, if I see guy with neck hole swimming, I'd be like, that's probably not a good idea. Things like that. Okay, so tuberculosis. He goes over the patho pretty deeply, and the patho is not really important too much. The main idea, I think this picture was in the PowerPoint. It does describe pretty much what goes on pretty well. The little bacteria makes its way to your lungs, alveoli, and your body is able to kind of like trap it in here into like this little tubercle things. At some point, like that's where your TB becomes like latent. So it's like you can have it, but it's not active. And then at some point, it kind of reactivates itself and kind of like eats up this tubercle little thing that your body has kind of encapsulated it in, makes its way through, and then you start like a active tuberculosis infection. But like I said, it's really not emphasized on the patho, more about pretty much everything else. But it's here if you want to read it. So latent phase versus having the caseous necrosis, the cheesy necrosis, kind of break through that capsule that your body made, and then now it's active tuberculosis spread around, etc. And then here is a potential reason for why it might become active. Your immune system's not as good. The granuloma that's created here doesn't hold it anymore, and it makes its way through, reactivates it. One of the most important things to know about TB, what kind of precaution is it? Is it droplet? Is it airway? What are we thinking? Yeah, it's going to be airborne. So what is airborne precaution kind of air? What is that kind of required? N95, yeah. Your N95. And here are some risk factors that I have listed. Those that have been in contact with active TB. That makes sense. IV drug users, people that are immunocompromised, crowded environments. That comes up a lot on like Kaplan questions and stuff. And so, people that are alcoholics because of weakened immune system, and then they included immigrants, poor socioeconomic status, homeless because of maybe poor diet, weakened immune systems. Um, yeah, that's pretty much that for that. Ironically, like a lot of immigrants, we've gotten the TB vaccine, so I've been vaccinated for TB. So technically I'm extra protected. Uh, but thankfully I never show up positive on the skin test, so I don't have to deal with the chest X-ray or whatever. That's cool. No, I was born in Peru. I came here when I was 7. Oh, that's pretty amazing. That my friend took a client to a meeting for housing things that are common. Oh, damn, that sucks. Yeah, that sucks. I'd be pretty mad if I had to get chest X-ray. But at least the skin thing is just like, okay, you make a little bubble on my skin. Yeah, so let's go back up here. So right here, one of the possible causes that can make it become active is maybe like a weakening of the immune system um, can cause it. So if it becomes latent and doesn't kind of goes from like you get the infection and it starts out latent for you and you have latent TB but not active TB, at some point if for something comes up where your immune system kind of loses its ground, then because if you kind of go back up here, your immune system here. So again, let's go back up here. You have droplets. Droplets make it to the alveoli, and I'll zoom in a little bit more so we can kind of see that. Let's go to 125%. This little purple thing right here, that's like the TB virus or bacteria actually. Bacteria. These are a bunch of little tubercle. These are the bacteria. This right here that you see here, this is your immune system that has encapsulated it. It basically kind of like how when you can have what's it called? An abscess. An abscess is basically like your body kind of surrounding and encapsulating kind of like an infection into like a single spot. Um, that's kind of like the same idea. It's kind of all encapsulated in this little thing right here. And then when your immune system becomes weakened or just kind of maybe just stress or like common things that can make an impact on that, the tubercles kind of overpower the immune system and it causes this like cheesy necrosis, makes its way through this encapsulation and breaks open, and now you have a lot of tubercles just out and about in your lung area, alveoli area, where then it becomes active. So that's kind of that. And it kind of makes sense. You see a lot of these things are involve weakened immune systems. This one's just like sharing of needles. Otherwise, weakened immune systems, being in close contacts with other people, which is how people get sick very often with like colds and whatnot. Especially because it's airborne. So, uh, okay. So, what are some manifestations of tuberculosis? What can you think of? Yeah, for sure. We're gonna have some coughing. Anything else that comes with the cough? Yeah, night sweats as well. Like a common one that people kind of have. Bloody. Yeah. So we'll go to um, coughing, and you'll likely have like a blood tinge. So what does blood pinch mean versus bloody sputum? So we talked about how lung cancer has hemoptysis. Hemoptysis is straight up coughing up blood. Blood tinge sputum means it's still sputum, but it's got some blood in it. So that's kind of like your difference there. And one of the key things here is that I believe with your tuberculosis, you'll have um like if you remember pneumonia has what they call like a rust colored sputum. Your tuberculosis has more like a bright red or pinkish tinted sputum, while your pneumonia is a little bit of a darker color because it's like old blood, which is kind of that differentiation between blood tinged versus rust colored. So I would say these are probably your main ones. There are some other ones that come up as well, like fatigue, and you can have a low grade fever. But these first three are probably like your biggest things to look out for. Yeah, and weight loss too. Yeah, weight loss. So I would know these, and especially especially these three out of them all. Probably the um most relevant ones. Moving on to the different diagnostics. You have your PPD that we've all had to do. How does that one work? What does it mean to be positive? Um, what is positive, etc.
Yep.
Yeah, positive is meaning exposure to TB. So what is a positive number? Like what is positive? Like what is the thing you're measuring with a PPD? And then where do you go from there as well? 15 mm for immunocompromised. So 15 mm is referring to what? What is it that's being measured? The lump, yes. So it's the induration, meaning like the swelling size, not necessarily the redness. So like for me, it gets like a decent spot of red, but it's never elevated. It's all about the induration. So they'll pass their finger over it and see if they feel anything, any lump. So the redness doesn't really matter. It's just about the induration. Okay. So we mentioned, yeah, 15 for immunocompromised, yeah. 10 for people that work in healthcare, people that are IV drug users, and then 5 or more for everybody else essentially. Well, actually, let me actually double check this one. It's 15 for actually, no, you have it backwards, actually, Kayla. Yeah, yeah, you have it backwards. It's 5 is for immunocompromised because the induration is how much it's elevated up. So smaller, higher than smaller number or smaller number.
Well,
What?
say,
Hmm?
trying to say.
That it's 5 or higher for immunocompromised.
Yeah.
10
So the screen
for.
is a touch screen, so
Oh, is it?
yeah.
I did not realize it was
Yeah,
touch
so
screen.
you're moving stuff on that.
That's funny. Okay. But yeah, so I have a picture for it. Um,
What do you mean? You were here when I set it up.
yeah, exactly. So 10, you're still right on the 10. It was just the 5 and the 15 that were kind of backwards. Because the bigger number means that it's worse reaction.
But if you're immunocompromised, you can't
Yeah.
generate reaction.
Yeah.
Reaction. Ouch.
So the idea is if you're immunocompromised and you have this smaller reaction, because you're immunocompromised, it's still considered positive for you. Now, this right here with the 5 mm referring to HIV positive, just keep in mind that this person, or it can even be with someone that's been in recent contact, is that people with AIDS can show up with no induration because they're so immunocompromised that they don't even have a reaction anymore. So kind of similar to how we talked about your liver, cirrhosis and your chronic pancreatitis, where it's so damaged that it no longer releases some of the enzymes. So as opposed to like where it's acute, where like the numbers are high, like in liver cirrhosis, the AST, ALT, ALP, they are high in acute liver if like liver problems, but in chronic cirrhosis, it's so damaged it doesn't even release them. So same idea here. HIV, your immune system is so far gone that it doesn't even make a reaction. So if someone that with AIDS can have no reaction, and you should still Therefore, treat them. They should be treated as if they still are at risk for tuberculosis, essentially. Similar to like when someone's getting like a MRSA screen and they haven't gotten the results, they'll treat them as a contact just for safety purposes. But in this scenario, if you are positive in your PPD, where do you go from there? So PPD positive means you've been exposed. So that's saying that you have latent TB. How do you rule out active TB? Where do you go from here? So three positive acid fast sputum cultures. That is one of the steps, but there's actually one thing you can do before, yeah, the chest X-ray. So PPD positive means you've been exposed. After that, they do a chest X-ray, and the chest X-ray is there to rule out active tuberculosis. So they will then use the your chest X-ray to see if you've got the little tuberculosis. They can spot the little thingy-mabobbers in there. And then I'll put this here as well, and kind of what we talked about, the BCG vaccine. A lot of the people that get it, not me though, because I'm just that good. They will they will usually show positive need to get chest X-ray. Um,
How old did you get the vaccination at?
huh?
How old were you when you got your vaccination? And how old are you supposed to be when you get that vaccination?
Um, I don't know actually. I think I was told I actually got it pretty young, like
Yeah.
right out of the NICU.
It makes me question if it was actually, if you generated enough of a reaction to it to form antibodies.
I'm
Is
sure
that
I
a
did.
shoulder scar?
Yeah, I have. It's very. Mine's not very noticeable.
Scar like that, but she ever got a TB shot, so I don't know what she got.
Did you ever live in the Philippines?
She was in Hawaii,
Oh.
where there's a lot of Filipino immigrants.
Mhm. Yeah, I was told that yeah, when they put the shot in, it didn't really my parents said that it usually like lumps up and gets like pus coming out of it, but for me,
Us.
or pus, whatever. But for me,
Oh, because
yeah,
I didn't
see, yeah, but like for me, it just got like really red, like a really red spot, and never lumped up. So I don't know if that means they put it in wrong or if my NICU, my meconium aspiration gave me my immunity or something.
That's why your PPD is maybe.
Why? You're saying it because I had like a different reaction to the vaccine, or like what do you mean?
They didn't do it.
No, I'm just gonna say I just got it like that.
No, because then you'd be generating a reaction to it.
I don't know.
That's my thought process.
All I know is technically I got
You
vaccinated.
are an enigma. That's what you are.
To be fair, I don't get sick in general very often.
This thing in general.
Yeah, so Kaylin like gets sick and she'll be like horribly sick for like a week, and then I get sick from her and I'm only sick for like a day.
You get sick.
If I get sick from her, yeah.
Actually get sick. I'm very upset. I don't want to talk to you right now.
And I always attribute my immunity to growing up drinking like Peruvian tap water. It gave me my immunity for free. But yeah. And then yeah, so chest X-ray is there to rule out the active tuberculosis, and then like Kayla mentioned, the acid fast one, they'll do times three, and this is there to be it's kind of there to it's a definitive, but it's also there to what's the word? To kind of see if you're contagious or not. So the idea is any positive result means you're contagious. And therefore, that means you need all of them to be negative consecutive. negatives. Going to be considered non-infected. And then again, if they want to look through, they want to look at your lungs, bronchoscopy is there. But again, don't hard memorize all of that stuff. You can kind of, you can, it's things that, as a nurse, you can, having like a very deep knowledge of the diagnostics helps you like predict things that will be done. But for the most part, you can look at your orders or like be aware it's like this procedure is being done, and as long as you're able to look at that and be like, yes, that makes sense for that, or it's like, oh, they're doing this instead of that. Like you don't really have to, unless you want to do MP, and then I guess you will be doing the prescribing.
Yay.
But yeah, just focus a lot on management, interventions, and complications for the tests and stuff. Yeah, I don't recall ever being like hardcore tested on like specific diagnostic, like in terms of like which ones do you order. I don't think that's ever really been like a
What's your question?
like being hardcore tested on like which diagnostic did you order. Maybe like at most like one or two questions.
Yeah,
Like
it's very, very minimal.
it's very minimal. But of course, if you see it, you should be able to look at it and be like, that would make sense for that. That's as far as you really need to know.
Mommy's got this indent. That's the one, right? It look like this, right? My mommy has that.
Kind of, yeah. That one's really pronounced.
My mom's is pretty pronounced.
But yeah, so some general education that is pretty important here. What can you guys think of for some education to someone that has tuberculosis?
Oh, you know.
So your education is also something that is important for you to know. Wear a mask, yeah. So we're gonna wear a mask until infection is non-contagious. What else can we think about?
Oh, smallpox vaccine apparently as well left a scar.
Oh, smallpox.
Smallpox vaccine, yeah.
Do Americans not get smallpox vaccine?
Yes,
Oh, they do.
yes.
Oh.
I think it's part of, what is it, MMR or something now?
Oh yeah.
The original formulation in the 70s left a scar apparently.
Oh really? Yeah, med compliance. Yes. So med compliance, kind of with like everything, med compliance is important, but yeah, especially because it's an infection, and yeah, we don't want to like stop your meds that treat an infection, or else they can develop like resistance, and you have mutations that make it even harder to treat. And then it's like, well, you have a super bacteria ready to contaminate other people. Yeah, these are like probably like two most obvious ones that we're definitely going to be treating. There's like a few that they mentioned that are a little weird, but
Oh, never mind. We don't vaccinate for smallpox anymore.
oh,
Did not know.
I don't know if you guys can remember them. They're a little bit weirder. These are probably the two main things to really keep in mind. So we said med compliance. What about things to kind of think about based on like some of the medication side effects? So a lot of these medications are particularly toxic to a particular organ. So what organ is it? And therefore like what kind of education would you kind of provide on that?
Yeah, that's my chapstick.
Huh?
That's bye. It's stuck.
Yeah, liver stuff. Liver. Yeah, a lot of the medications for tuberculosis are hepatotoxic, so they are not good for your liver. So avoiding alcohol, and this one, I mean, you're not going to tell the patient avoid hepatotoxic medications because they're not going to know what that means. So you're probably going to talk to them about like common things, or or even better, like tell them before you take any over-the-counter medications, talk to your doctor. I mean, that's a good question, honestly. It it's kind of like, you do your best with what you got. Um, you're gonna do risk versus reward. So the idea is, you have liver cirrhosis, and your liver's not gonna like the medication, but otherwise you die. So you take the medication anyway and hope for the best. So that's kind of another thing to think about. And I know someone mentioned flushing things out as well. Drink a lot of fluids. Drink a lot of fluids is good because it helps to flush out some of the uric acid. Um, I would say that's pretty much that. And then obviously you're looking for um the liver impairment. So if they're jaundiced up, if they're starting to bruise, etc. And here's another random one that I definitely don't think gets tested on, but some of them can inactivate your birth control. So yeah, gotta be careful. Although I guess it'd be very interesting, I guess, if you had active TB and then you were just like, just like, all right, it's time. Yeah, rifampin. So what to do if somebody believes that they're exposed? What's like if someone thinks they've been exposed to it, what do you kind of have to do? Or what should they do? They don't have active TB, but they think they were exposed to avoid infection.
Cry about it.
Oh yeah, so if somebody believes that they were exposed, what should they do? Or what should they be taking? Like what's your like go-to medication? Because you have a list of a lot. You have like a list of like four meds, but which one's like the most important one to prevent infection? Yeah, the INH, yeah, the isoniazid. That's gonna be your main one. So isoniazid, I think it's like 6 to 9 months to avoid infection. And we mentioned strict adherence to meds. They do have something called direct observation therapy. So that's the making sure that they take their meds. Um, and I think in the lecture, Mr. Robbins mentioned how like there's like if someone doesn't want to take their meds, maybe like I think he mentions like a homeless man. Yeah, like he mentions like, oh, there's a homeless man, so maybe you can try to offer them food and water so that they like incentivize to take their meds. Yeah, something like that. And I believe to some like at some point, because tuberculosis is so contagious, it's airborne. They can force you to take the medication. It can be
Yes, they.
they can get police involved, and then you will be forced to take your meds because it is a public hazard.
It's not just a you problem
Yeah.
anymore.
Yeah, so that's a thing that can occur. So psych is not the only time that they will strip your autonomy away, or lock psych rather, where they can strip your autonomy away. Yeah, they will make you take that damn thing.
Ow.
All right, so now let's talk about the specific medication. Um, and kind of let's kind of list some of the generic things that kind of go down with these meds. So isoniazid, you mentioned that this is going to be your probably your main one. Uh, We mentioned it's toxic to the liver. These are all going to be hepatotoxic for the most part. And this one comes with like a risk of something in particular. Yeah, peripheral neuropathy. And it stated that for that you want to take vitamin B6. And in case they give the government name paroxetine,
Not the government.
reduced risk. That's gonna be your main thing.
I just found out what that was.
What, paroxetine?
Yeah.
Oh, because in the med card they usually don't call them vitamin B6. They call them by the
I pulled that and I was like, wait, what is this?
and you're just giving vitamin. That's funny.
I had to figure that.
Yeah, yeah.
Yeah, I got it.
All right. So that's honestly as much as you need to really know. Now let's talk about rifampin. You mentioned that it's toxic to the liver. Most of these are going to be liver toxic. So we kind of already know what goes on with that. We know that we can get pregnant. Well, I can't get pregnant, as far as I know. Ow.
Bro, what the fuck?
Yeah,
Oh,
so
bro.
it can activate your birth control. And then what else is something that gets commonly brought up with this medication?
You gotta get the shot, bro. The depo shot.
Like a side effect that might freak people out. Yeah, the color, that can turn bodily fluids into orange color. And this is normal. This is expected and it's normal.
Bro, I crushed them in. I swear to God, it looked like hot sauce.
What medication?
Yeah.
It looks like hot sauce?
Yeah.
What do you mean it look like hot
Well,
sauce?
I push it through you guys' G-tube.
Oh, okay.
When you crush it and put it with water, it looked like hot sauce.
I see. Interesting.
And I kept calling it the hot sauce.
Hot
the rest
sauce.
of the time I was there.
That sounds funny.
The hot sauce.
Hot
It
sauce.
was. It looked like hot sauce.
Mhm.
I stand by that.
And I would say that these two are like the two main medications that will be kind of done. You can tell because it's the one that gets taken for a full year, while these other two get taken for a shorter period of time. Um, and I do have a way to remember some of the stuff that can happen with this one. So I guess we can talk about like what can happen with this one. What's like the main thing to think about with ethambutol? Because there's two things with it, but there's probably one. There's gout, yeah. So there is gout. Something with the eye, yeah. So I remember this as E because it starts with an E. E for eye. You have optic neuritis, so inflammation of the optic nerve. So this can include vision change. But the most important thing to note is that once med is stopped, the symptoms should go away. So it's a temporary thing. But yeah, I for eye, E for eye. And then gout, we know about gout is due to increase in uric acid. And we talked about before, you want to flush it out with fluids. And allopurinol as well to treat. And then gout is basically just like a buildup of uric acid and it can cause joint pain and stuff like that. And now there's PCA. Um, with this one, I remember it as P for photosensitivity. Sensitivity. So these people should get like sunscreen, protective clothing. And again, this is toxic to the liver and can cause gout.
Yeah.
So cool thing about these is that you can kind of do this memorization trick here. But we're already kind of clustering them together because they're both the ones that are done in the first 2 to 3 months, and they're also the ones that can cause gout. So they're both you can kind of whoops, this should be like so you can kind of cluster them that way as well. Any questions on anything we've talked about so far? Anything about tuberculosis that you would want to get answered? Otherwise, we can just move on to pulmonary embolism and then general pleural space stuff. Okay. Pulmonary embolism. We definitely know a little bit about this just because we've talked about DBT before. You maybe have seen it in clinical, but it's essentially an embolism that makes it to your lungs. And that could be air, like an air embolism, could be blood, could be a like a blood clot, could be a fat, like a fat embolism. The main point of the matter is that you have something that is impeding the exchange of oxygen and the exchange of oxygen in the lungs, and therefore impeding the ability for your heart to then get oxygenated blood back from the lungs. So, what are some risk factors that you guys can think about for pulmonary embolism? And then for this one, the risk factors are definitely is definitely something that I want you guys to definitely be aware. Ouch. And you'll notice that, yeah, a lot of these are similar risk factors to DBT because this can come a lot from like a DBT leading to leading to all that stuff. So examples include being bedbound. It includes being like post-op. It even includes something like just being another form of immobility, like being on a long flight. I think during lecture he mentioned like someone coming from a flight, coming from like a flight China or something, stuff like that. Stuff like that, right? So like these people are at high risk of developing a PE because they're at a high risk of developing a DVT because they've been sitting down on a flight, not moving around for so long. And yes, contraceptives is great. With contraceptives, people on or if you recall from OB, the way contraceptives work, increase your risk of clotting because they're trying to simulate pregnancy, and when you're pregnant, you're hypercoagulable because the body expects to bleed out because there's gonna be a little like parasite in your stomach or in your uterus trying to come out. Yes, PICC lines. So PICC lines have a higher risk. PICC lines and then midlines have a higher risk of developing those clots in the arms, which can then, of course, make its way over and lead to a pulmonary embolism. 100%. We mentioned alcohol. We mentioned definitely smoking because it's a constrictive. So smoking. Um, I'll put CVAD, so central line removal, because air embolism, chemotherapy can lead to clots. Chemotherapy. Mentioned fat embolism, so someone like a long bone fracture. And then some another things that can lead to it. AFib can also lead to it. Although AFib is more likely to lead to like a stroke than anything, or like an MI or a stroke. It technically can still lead to something like that. And then dehydration is a big one that people forget about because your blood becomes, becomes thick because it is kind of like, yeah, it gets really hemoconcentrated. So think of it like um and I would actually even put like hemoconcentration instead. So hemoconcentration, and that can include dehydration. Even like being a diabetic, having your blood sugar be really high for a long period of time can increase your risk because of the hemoconcentration. The idea is it becomes more viscous. So like with the diabetes example, It's really easy to think of it like you have kind of like honey. Like honey is like a more viscous kind of thing. That's kind of how you're maybe not literally, but the kind of the idea is there where it's more likely to clot up and get stuck because it's so thick and viscous. And that can occur because there's less fluid or because there's stuff in the fluid, like diabetes, like you have a lot of sugar in there for like diabetes. Makes sense for this? Cool. Here's a picture. I think it's pretty nice. I like having the pictures because I think makes things easier to remember. But yeah, go ahead and list some of the, I mean, it's kind of already listed here, but some of the things that come to mind immediately, that kind of for signs and symptoms. Go ahead and list it in the chat and we'll kind of fill it out. So for manifestations, just list out some of the manifestations and we'll fill it out. That's it. Shortness of breath, tachypnea, chest pain, tachycardia. Perfect. So a lot of those are going to be some of the things that come like sudden onset. So perfect. So I'll just list some of the ones we have here. Yeah, tachypnea, tachycardia, chest pain, shortness of breath, and then some of the other ones that we could potentially see that I know is really obvious. So hypoxia, that's going to be a massive, sign that's you're having difficulty with exchange of your oxygen. So hypoxia, of course, that one's pretty obvious on that one. Um, how do you think what do you think the blood pressure could be like? So we have one person saying increase, one person saying low, and the answer is technically a little bit of both. So you can start hypertensive, and then that becomes hypotension as you're decompensating. So hypertension because of compensation initially, and then later on, um, it becomes low because fully like decompensating and you're not making you're not meeting your goals. Similar idea to kind of like someone having respiratory failure. They will initially have high respiration rate, and then as they're starting to fail to compensate, they'll start breathing slower and slower until they just stop breathing entirely. Orthopnea be a late sign for this. Mm, orthopnea as in like difficulty breathing based on position or like I'm not really sure if the positioning matters. I mean, I'm sure I'm sure it does. Just
they're gonna have a hard time breathing
Yeah.
in one way or the other.
Yeah.
Because the fact of the matter is the clot is
yeah.
impairing their
I
fecal.
feel like it, I feel like it doesn't matter as much because I feel like because it's all happening internal. Like regardless, they're gonna have that obstruction in that blood vessel that's preventing the exchange. So I feel like it's not necessarily gonna really be positional based as much, but
They're gonna struggle one
they're
way or the
still they're
other.
still gonna struggle. Yeah, they're gonna struggle one way or the other. But I mean, regardless, you probably still want them head of the bed up because you're gonna do your best to like with what you got. But of course, just know that like how would you respond to this? Like, let's say you have a patient with a DVT and then they have all of these complaints right here. They're like, oh, I'm like they're having chest pain, short of breath, short of breath. Um, they're getting stressed out and like what is your like how do you approach it as a nurse? Like what can you do?
Right. But what do you believe?
Head of the bed up. Okay. Maybe try to increase their O2. Where do you go from there? So like that's gonna be your initial response to like someone struggling a little bit more to breathe. Okay, cool. Let's say it's not helping. Less from Dallenberg if they're having like an air embolism. But in this case, it was a DVT. It started as a DVT, so this is like a classic pulmonary embolism instead of like an air embolism. Where do you go from there? So head of the bed up, O2. You put some O2 on them, or you're titrating it. It's not helping. Where do you go from there? Okay. You can listen to lung sounds. But now imagine this person's decompensating in the room with you. You're doing interventions and it's not working. Call RT. Yeah, that's what I was looking for. Because you're not gonna do too much on your own.
So you're gonna be able to do.
Non-rebreather, that can you can do your best to do that. So realistically, with someone with pulmonary embolism, if you remember, their main issue is that they have that clot in their lungs, which is impeding the exchange of O2. So it's likely that the O2, increasing the percentage of the O2 is not actually going to help much because their issue is like exchange.
But that was one of the things you're supposed to do, huh?
Yeah, but it's not going to get into it.
I mean, they need clot buster, but for
Yeah.
short term, what we could do in the room.
No, yeah, that's what I'm saying. Yeah.
Okay.
Yeah. So you can do that and but you'll probably see that it's not going to help as much. You still want to do it, but it's not gonna like fix it because their main issue is like oxygen exchange. So calling RRT and this person might be intubated because they're gonna need a vent to kind of help them out because this person is not going to be as responsive to an O to the O2 because again their issue is the exchange. So it doesn't matter what the percentage is. Do you know how long it would take for it to be fatal? That's a good question. It might be very dependent on the size of that clot and like how much it's killing off and everything. I don't really have a timeline for it, but it'd be kind of like I mean, if it's coming from like a DBT, you might already kind of like be predicting it because it's like if you have no history of respiratory issues and you have a DBT, an active DBT, and then you start having all this chest pain and tachy, you can kind of already be like, okay, this is probably a pulmonary embolism. Um, I'm gonna put the head of the bed up, call RRT, and then during that time we're gonna do our best. Maybe you even skip the nasal cannula, you just go straight into like a non-rebreather
Fuck, I would.
to try to help them. And then wait for RRT to get there, and then doctor can uh, intubate the person. You'll learn a little bit more about all that process in 240 because that's critical care. But that's kind of how that would go. So when in doubt, RRT because you're not going to be able to deal with everything, and this is one of the things that you don't really have anything you can do other than calling for more help. Some of the non-invasive interventions aren't really going to be as effective, just based on the etiology of the condition. But yeah, so it's kind of like, like knowing it came from like a DBT. When it's a little bit more vague, like it comes from like something else or based on something else, like when you don't have like an obvious clot that was already there that moved its way up. It could be a little bit more vague and therefore it can be a little bit harder. So doing a little bit more of like assessing for lung sounds, et cetera, like, crackles, for example. Um, some of that stuff that can occur. They could also cough up blood. That's another one, like full coughing of blood. Um, but yeah, the context helps for that. But whenever you're in doubt, doing a calling a rapid's always a good idea. Okay, and we talked a lot about some of the assessment part. You said lung sounds. You can hear potentially crackles. They'll have chest pain. We're gonna place the head of the bed up. We're gonna try O2 supplementation, but just remember that this person will probably need to be intubated, so we can try O2 supplementation. Um, but then likely we're gonna be hitting them up with a non-rebreather and calling in our RRT for possible intubation. Okay. So other things that can occur is if you guys recall all the way back from 212, cardiac. We have two different types of heart failure, left-sided heart failure, where you have pulmonary edema, and then right-sided heart failure, which um, is peripheral edema. And a lot of the times your right-sided heart failure comes from um, worsening left-sided heart failure. But right-sided heart failure can also come from issues with the lungs. So one of the names for right-sided heart failure was or pulmonale, meaning kind of like heart lung. This is because we have right-sided heart failure due to pulmonary hypertension due to the pulmonary embolism. And that's also the same reason someone with COPD can get right-sided heart failure because the COPD person can have issues with their lungs leading to pulmonary hypertension. And if you have pulmonary hypertension, it means the right side of your heart is having a harder time getting blood to the lungs to make the exchange. And therefore you have backing up of blood on the right side of the heart, which is where um, that starts to come in. And then if it's building up in the right side of the heart, it's backing up into the body, which is where you get peripheral edema. Let's see what Diane said. Must be clinical and patient at PE due to DVT bilateral. Bilateral. Yeah. And a non-rebreather with an O2 machine delivering 48 liters per minute with a 2-liter inhalation fluid handling. Sheesh.
Dan, you always be getting the craziest patients, I
Yeah.
swear to you.
God
You
damn.
should always be getting some crazy people.
But what site are you at? What's your clinical site? Tele. What hospital?
I'm gonna call
Cardiac
PIH.
cardiac tele PIH, I'm guessing.
I'm gonna call
Whittier?
PIH right
I'm
now.
gonna guess Whittier.
I'm calling it. I'm calling it. He's not replying. I feel like I'm wrong.
PIH Whittier maybe? Oh, Lakewood. Oh, wow.
Oh, oh, oh.
Interesting.
I didn't even know they had those kind of patients.
I didn't know either. Usually, well, they have their med surge tele. Technically every unit there is tele. Everybody has a heart box even if they don't need it. Yeah, interesting.
Well, damn.
I'm surprised they were not in the DOU.
This man had a great time.
So it was in West. Was it in West? Yeah. Huh. I'm surprised they weren't in North. Oh well, it happened. He was declining. Yeah, he probably should have been sent to. Yeah, he should have been sent to like ICU or the COU. Yeah, I don't think he should be on that floor, but there's a lot of people that should not be on that on in that on that med surg. That's why med surg totally sucks. Because you're gonna have people that don't belong on your floor.
Always.
Which I mean, I guess means you get to send them over to ICU or step down. Probably ICU in this case. But then it means you have a new admin, which also sucks, but it is what it's what it is. Yeah. So other things that can go with heart arrhythmias. No, there's a lot of content. It really is. Cardiogenic shock. So makes sense though, the shock, because your lungs and your heart are so closely like aligned with each other. They work together to get O2 out to your cells. Um, if you're having issues with the lungs, like we mentioned, it makes it harder for your heart to pump um, to there, and then it can make, in general, it can just make things back up. And if you're having hard time pumping things through, you can get cardiogenic shock, which is pump failure.
Yay.
So that's kind of where you can kind of make that connection there. Arrhythmias, if I had to guess for why, I mean, like you said, the heart and the lungs are associated together. When you're stressed out, um, like this, especially because the cardiogenic shock also kind of goes with why you're hypotensive when you're decompensating really bad. When you're kind of going into like severe decompensation, your body releases some of its, fight or flight hormones like norepinephrine, epinephrine, dopamine, all that stuff. And all of that stuff and like a huge surge can lead to heart arrhythmias. So that's probably that connection there, alongside just like, lungs and heart, they go together. Even like, lungs and heart go together, even your beta receptors,
Beta.
can affect lungs and heart. They kind of go together, so that's kind of where that kind of goes. So heart and lungs, they go together. For vital signs, we already talked about all this stuff here. Yeah. And then when you guys get to 240, we can have a lot of fun discussing the different types of respiratory failure, ventilatory failure versus oxygenation failure. In this case, pulmonary embolism is an oxygenation failure, which makes sense because that's the whole exchange is gone. So when you have all that, there's really uh, not too much you can do. You have to like intubate, while ventilatory failure means that you're having issues just breathing. Um, in which case the higher O2 doesn't even help because you're not breathing in like fast enough, and there's a whole lot. It gets more complicated. So, but before you freak out, 240 is honestly is easier than this class in terms of tests and stuff. Our averages for 232, I think we're like low 80s, and then I think for 240, our averages for our tests were like mid 80s. So pretty doable, pretty doable. Pretty doable. Don't freak out yet. But yes, you do have another respiratory section in 240.
Yay.
Yay. It's a little bit more interesting though. It's like ventilation, ventilators, and stuff like that. And it's pretty cool if you're interested in like doing ICU and stuff. You get to learn stuff. But it's ironic because critical care is not even tested in the NCLEX anymore. So like yeah, not very minimally. Which is ironic because they test on OB and peds, but like whatever. Although I didn't really get any. Didn't really get very many peds or OB questions, so it's like okay,
I
that's
got a lot of peds. I got some OB.
actually I got more, yeah, I got more OB than I did get peds.
Everyone seemed to be a bit different though, for obvious reasons. So.
All right. Chest x-ray. Try to get you guys out on a good time. So chest x-ray to rule out pneumonia or other issues like pneumothorax. PTX is pneumothorax. And PNA is pneumonia.
Pneuma.
ABGs, just like in the picture, it mentions that the ABGs will be like respiratory alkalosis initially because you're hyperventilating, kind of like how initially you're compensating and you're going to be hypertensive, you're stressed out, hypertensive, your body releases all the fight or flight hormones, etc. And then you will be respiratory acidosis due to poor oxygenation. And we will talk more about like ABGs and like the whole process of ventilation in 240. But I always thought it was funny because it's not like if someone's decompensating, you're not gonna take an ABG, wait for it to go through before making the decision to intubate. So it's just like kind of like when are you doing that? You're just gonna go for it because you have a limited time before they just die, or they're so inflamed that you can't get the airway in. So I always thought that was weird. Do I have a better one? So, they're cool. So VQ scan. The VQ scan, V for ventilation, Q for some reason is for perfusion. But here is actually a pretty good picture that kind of explains it. Really, all you have to know about VQ, the VQ scan, the VQ mismatch, is that it's basically saying like kind of what we've been saying that it is perfusion. Oh, sorry, it is ventilation without perfusion. And here you see one right here. This side right here is the example is like a pulmonary embolism. So a normal one, you have an alveoli with the air. You have the vessels in the lungs. They exchange O2 and CO2 to then go back to the lungs to then pump out to the body. When you have pulmonary embolism, you have the air in the alveoli, but the vessels have a clot, so you're not able to make this exchange. So that's kind of where it gets hard and whatnot. And then here's airway obstruction if you were curious, where naturally you see there's no air in the alveoli. Blood flow is fine, no air in the alveoli. There's also a spiral CT to diagnose it, not as invasive. It uses contrast. Really don't think there's too much that's particularly crazy about this one. It's just like a knowledge thing that, again, I don't think it's directly tested on, so you can chill out. Again, because it uses contrast, contrasts are nephrotoxic, toxic to the kidneys, so he likes mucomist, kidney protective. Fibrinolytics, those are the clot busters. So example is your alteplase, your RTPA, TPA. The risk of a clot buster is the risk of bleeding. You're monitoring the vital signs because risk of bleeding, and then kind of seeing how it's affecting the process, mental status, seeing again how it's fixing it or how it's helping. And we mentioned bleeding. The anticoagulation therapy, that's kind of where the heparin drip comes in. Heparin drip, does it break down clots or what does it do? How does heparin work?
Oh. Oh.
Yeah, it prevents the clot from getting bigger, but it's not going to decrease the size. So it is right here. Boom, that's given for an active clot as opposed to a heparin injection, which is there to prevent DVT. Heparin drip is for active clot. That is the difference. What are the values? What are the lab values you're looking at? Yeah, PTT, and you're still looking at platelets, but this one you're looking at PTT and platelet. When you're giving a subcute heparin, you don't particularly look at the PTT. You'll look more at the platelets, but when it's heparin drip, you are basing things off the PTT. And this kind of goes, how often is that done? Yeah, about every done about every 6 to 8 hours. I think Q6 is more common. And then here, your PTT should be roughly 2 times the normal. If your normal is 35 to 45, then the heparin drip should be about 60 to 80. But it depends on the goal because every condition is going to have a different goal. And the reason you assess their platelets is because of the risk of HIT, which is heparin-induced thrombocytopenia, aka bleedy time bleeding. You're going to assess for bleeding, and your antidote is protamine sulfate. So there's an antidote for it if you go crazy. But if I recall, your heparin drip is also doesn't like once you stop your heparin drip, it's it doesn't stay in your body too long. Maybe like for like a few hours, maybe like 1 or 2 hours, it'll still be in your system, and then your PTT will go back. Your clotting stuff will kind of go back down to normal pretty quickly. But something that's important is that it must be run in its own line. That's definitely an important thing for Kaplan and or for this test. So if someone's going to have a heparin line, they're going to need an extra line, at least another IV, just in case, or a central line. This is something that I think is important because I don't know if he gives you guys like a study guide or anything. I don't know if he did, but I think this is important to know. So I would highlight this here. So the idea between bridging into Coumadin is that somebody that like has had a PE will have to be on an anticoagulant then from that point on. I guess back in the day it used to be Coumadin. Nowadays it's usually Eliquis, but they're still teaching Coumadin stuff here. So the idea is they're going to be, Coumadin is not going to be as, it's going to take a little bit to build up in the body to take effect. So the bridging is essentially that they're going to be on heparin drip, um, and on Coumadin at the same time, waiting for and then of course making adjustments so that it's safe for the patient and whatnot, until that INR is there to that therapeutic range, which on Coumadin should be 2 to 3. And then once, I spelled therapeutic wrong, that looks right. Therapeutic. Oh, I think you spelled E. Is that right? No, that doesn't look right. I think I spelled it right. Whatever. Once it gets to that level, they can stop the heparin because now that patient's at a level where they want them to be to prevent more clots in the future. And like I said, the heparin doesn't really last too long in the body once it's DC'd. So that's kind of the idea because Coumadin takes a while to take effect. They're on both until it's safe for them to only be on Coumadin. For some education, that's important. We talked about consistent vitamin K, avoiding all the G words because the G words increase risk of bleeding. Soft bristle toothbrush to prevent bleeding in the mouth. Of course, you're assessing for bleeding, and then the hydration parts to reduce hemoglobin concentration to make blood less thick. So your prevention here is going to be basically about DVT prevention stuff. So that's going to include stuff you guys already know about preventing DVT. So ambulation, SCDs, kind of doing foot pumps in the bedside if they're not going to get up, having good hydration, etc., etc. But if they have a DVT now actively, we want to not massage the leg. We want to try to keep the leg still and try not to move the leg. Something else that he probably mentioned is in regards to like the SEDs. So if there's SEDs on, but they develop a DVT anyways, I think the best course of action is to stop the SEDs, but to keep the SEDs on, like on the person physically. The idea being, okay, we're going to turn it off, the machine, so that it's not pumping the clot up, but we're not going to remove the SCDs because the SCDs are applying some amount of pressure on the leg at that point, and if you take them off, you might move the leg and dislocate the clot. Any questions on this so far? I know we've been going on a long time, been 2.5 hours.
Bro, it almost been 3 hours.
Yeah, we still got, honestly, we still got a decent amount. We think we still got a decent amount. I thought this one was shorter, this one's actually longer, my bad.
He's fire.
For the most part, this part's pretty similar though. The pleural space, you can have air and blood in there. You can diagnose it with chest x-rays. You will have a lot of the same side effects or signs and symptoms as you do with a lot of this with your with your pulmonary embolism, very similar signs and symptoms that you will have. So you can cluster them together that way. He mentions tension pneumothorax, which requires a chest tube, and it's a medical emergency, but you don't have to know it past that. The only thing I want you guys to know for this is that the word paradoxical breathing applies only to the tension pneumothorax. Paradoxical breathing means that you are breathing in and your lungs are actually deflating and then they inflate when you breathe out instead, which is very weird because it's all due to like weird change in pressure. Tension pneumothorax is highly pressure based. So the only thing you have to know is that paradoxical breathing only applies to the tension one. So if you happen to get a select all that apply for pneumothorax, paradoxical breathing is not going to be one of the answers because this is only for tension pneumothorax. Okay. Then we have chest tube, which we'll talk about a little bit more. Assessments that are very obvious, and we've gone over a billion times. So all of that makes sense. I mean, it's just basically, you have a pleural space. You can have fluid in the pleural space. Signs and symptoms are the same that you've been seeing this whole time. And to get rid of it, a chest tube or I guess a thoracentesis. Is done. Actually, sorry, I'm thinking of a pleural effusion. Okay. Just chest tube. Pleural effusion is thoracentesis will be for the pleural effusion, which is fluid in the pleural space. Here are some causes. Don't have to memorize it. Pancreatitis, if you remember from last week, can lead to pleural effusions because of the fistulas. And then here the management is thoracentesis. Get it out of the pleural space. Oopsies. All right. Empyema is just pus in the pleural space. And now thoracentesis, this is basically a long needle into the pleural space to get rid of some of it. You can even analyze some of the fluid that's there. Some of the stuff here is going to be stuff that you might see on a Kaplan exam. So I'll just post it. Boom. The person's going to be sitting up, leaning over the side table. So you're going to get like their little table thing. And they're going to do like a tripod position on there. Naturally, you're going to be assessing for the respiratory status after. It should improve. But it's worth noting that your thoracentesis can sometimes cause a pneumothorax because it was done incorrectly. Because it's invasive, you're watching out for infection, bleeding, etc. You want to do the chest x-ray because of the risk of pneumothorax. Etc. Vital signs because it's a procedure. Complications we talked about, hemothorax. The post-procedure, I don't think you get asked this much. Just always remember good lung down. Always remember you gotta do a follow-up x-ray. Signs and symptoms of your other stuff that we talked about. And then some stuff that you're gonna document is the amount of fluid and whatnot. But that's pretty obvious. If you see that on a multiple choice or whatever, it should be pretty self-explanatory. And I know I just went over this part really fast, but do we have any questions on this part here of the pleural space? It's pretty self-explanatory though. Your pneumothorax, hemothorax with chest tubes, your pleural effusion with a thoracentesis, and it's invasive. Therefore, you do all the stuff post-op that deals with invasive stuff. Any questions? Cool. So how much more do we have? We have a lot, but some of this is extra information. So again, this is for context on ABGs that is extra. You only for this test, you only have to interpret them. That's it. So we're actually almost done, actually, genuinely. Your chest tube. I have all the information on chest tubes here. And here's like a picture of it. So the ones at Lakewood look like this, the atrium, and I think the ones in the skills lab are also this one, the atrium. But here you can kind of see the suction control. Suction control is your pressure. Honestly, the main thing you have to know about chest tubes is knowing about the water seal. So the water seal is this little chamber That's kind of hard to see in this picture, but it has like different numbers like 1, 2, 3, 4, 5. And you're looking for consistent bubbles, which is a sign of an air leak. And the higher the number it goes to, so the worse it is. So there's like levels 1 through 5. But yeah, the main thing is water seal, air bubbles, that's an air leak. And that's not good. But it's worth noting that at the very beginning of treatment, that can be expected because you're releasing so much air or whatnot from that point. If you have an air leak, you have to clamp it near the patient's side and then look at the water seal again. If the bubbles stop, that means the air leak was essentially dealt with, and because you clamp the patient side, implies that the leak is happening patient side. So you have to unclamp because you cannot leave it clamped. Do not leave it clamped. And then call the surgeon because they're going to have to make an adjustment. If you clamp at the patient's side and the bubbling still happens, that implies that the air leak is actually system side, in which case you can unclamp and then try to fix the system. And to do that, you can leave the well, what's the thing? You can I believe you're allowed to take the part that's connected to the patient and then put it in like leave it to what they call like suction, right? Like the water suction.
Water seal?
Water seal, right? Like that. Let's say that the system is not the part that's wrong. You're gonna replace the system, but the part that's attached to the patient then goes into like some sort of like fluid, right? Like water.
The way I like to think about it is quite literally like a cup on the ground.
I think that's it, right? There's no like extra suction you have.
No,
it's just-
don't attach it to suction or anything.
Yeah.
It's keeping it quote unquote water seal, aka you put the end of it into some kind of sterile solution.
Okay, perfect. So unclamped and fixed system.
He'd say perfect.
Perfect. Patients, tubing side
Wow.
and be placed into a sterile solution. So like a cup of sterile water, cup of normal saline. If the chest tube is ever disconnected, then you want to apply the Vaseline gauze and then call rapid response.
Um,
And you should not try to reinsert the tube. Just put the little gauze in it. So that's going to be something you're going to need at the bedside. You're going to need your clamps, you're going to need the gauze, and that's kind of how you do it. If there's an air leak, you clamp an air leak only in the water seal. You can't, the suction control, which is the part that's not the water seal here, you will see that have some bubbling, and that's expected bubbling. So don't get confused between suction and water seal. Water seal is there to detect air leaks, bubbling there. Consistent bubbling is not expected at the water seal.
supposed to be sealed.
Yeah, it's supposed to be sealed, so there's not supposed to be any bubbles. And I can't remember which one it is, but one of them should have something called titling, which it just means that it kind of goes with your breathing. I think that's the suction control. It'll be up and down.
Oh, that was the water.
Or maybe it is the water seal. I don't remember exactly. I don't remember if the titling happens in the water seal or the
Does it not say here?
it doesn't, surprisingly. But that's expected. Titling is expected in the water seal. Okay, cool. So it's all water seal.
Yeah, 'cause I was like, the suction is where the bubbles
Yeah.
are supposed to happen. So how are you supposed to see the waves if the bubbles are there?
I wasn't,
The
True.
bubbles.
Yeah.
The bubbles.
So I guess it's the water seal. So titling just refers to it going up and down, which goes with your breathing. Any questions on this? Because I know this part gets confusing, and if I recall his lecture, he misspeaks and then corrects himself. So that was kind of confusing. But really just focus on the water seal. The water seal and the suction control are the only really important parts. So just watch out for that wording because that's really all you have to know is bubbling is expected in the suction. Water seal, it is not expected unless it's very early. And it signifies water or air leak. And understand like how to do the clamping, like understand like the concept of the clamping and why this means what it means. If there's any questions on the clamping part of it and the assessment of the system, just let me know in the comments. I guess technically this is a YouTube video at some point, so I guess but in the chat. This is also important. And then this is like some of your criteria. I think I need this stuff here. The only other stuff I would know is probably this stuff. So what to have at bedside. Um, this is important is how much is too much drainage. So once it's already been like past that first bit of time, where it's gonna be it's gonna be doing like the most amount of drainage, then you're looking for anything more than 70 mLs per hour could be indicative of hemorrhaging. Again, let me know if there's any questions. The last thing you have to do is ABGs, but ABGs is just interpretation of what it is. So here, this really, what you have here should break it down for you. The way I do it is I just look at the pH, determine if it's acidic or basic. Then I try to match it with one of these, either one of these. And here it explains how to think of either one. Once you match it, you know if that's respiratory versus metabolic. Your CO2 being respiratory, your bicarb being metabolic. And then just don't get confused by the fact that they're kind of opposite. So when CO2 is high, it's acidic, but when bicarb is high, it's basic. So try to get that stuff down. And if that's still doing it the way I do it doesn't help you, there's this video here. This is by I think there's Sarah on the Rome method, which is a different way of doing it that might work for you. So if it does, you can go ahead and do it like that. Here I wrote the way I do it. So if that helps you, do it that way then. So do we need to know compensation? Not for this one. I don't believe. I think you do for 240. In 240, you'll have fill in the blanks for this. So you have to, yeah, fill in the blank, include the compensations. But I don't think for this test we needed to know compensations. But if you wanted to know it, it's still explained in the video and it's explained in here. And here's extra information that is not on the test, but this is just kind of explaining the patho and some of the treatment for ABGs, but it's extra. You don't need to know it for this class or for 240. But they were pretty vague so I like in 240, so I like wrote it down and was like, okay, just in case. But then it was just interpretation again. But if you're curious, here it is. But again, not on the test right here. Any questions on anything we discussed? So, don't be shy. So is that we did spend like basically 3 hours. Thank you for coming to my TED Talk. And I know I went at a pretty fast pace. Last rotation, I actually split these into 2 sessions, but due to work and stuff, I just have the one in me. Yeah, and I know you guys have the test coming up. That's the tuberculosis, and I already posted the other one, but I'll repost it because why not? Yeah, of course. Stop recording now.